I'm Dr. Fakir Ravari, and this is Cirrhosis in Adults, Day 1. Cirrhosis is the irreversible fibrosis of the liver. It is the 8th leading cause of death in the United States, accounting for more than 28,000 deaths annually. Globally, it is the 13th leading cause of death. In patients with cirrhosis, risk of death is almost 5 times as general population. The average life expectancy in compensated cirrhosis is about 10 to 13 years. And it can be as low as 2 years in patients with decompensated cirrhosis. Now, in patients with alcoholic cirrhosis, those who abstain from drinking alcohol, about 65% of them are still alive in 3 years. Whereas those who continue to drink, 0% are alive in 3 years. So abstinence from alcohol is extremely important in patients with cirrhosis. Let's take a look at the function of the liver. So the liver is responsible for formation and secretion of the bile. It is also responsible for nutrient and vitamin metabolism, such as glucose and other carbohydrates, amino acids, lipids, and vitamins. The liver is also responsible for inactivation of various substances, such as toxins, steroids, and other hormones. One of the important functions of the liver is the synthesis of plasma proteins. These plasma proteins include acute phase proteins such as C-reactive proteins, albumin, clotting factors, steroid binding, and other hormone binding proteins. In particular, albumin is extremely important because albumin actually carries hormones, fatty acids, and specifically drugs. 38 to 45% of albumin is actually intravascular, so it holds on to fluids in the bloodstream. Another thing that's extremely important is clotting factors, which are also proteins that are made in the liver. And what they do is that they are involved in coagulation cascade. So you can see in this picture that there are a few clotting factors that are activated in a cascade style, and the final step in the cascade is the actual clot formation. So if there are not enough clotting factors made by the liver, then it is difficult for the body to form clots, leading to coagulation disorders. Now let's take a look at the portal venous system. So in this picture you can see the liver. You can also see a few other organs such as the stomach, the spleen, and also in the back you can see the inferior vena cava. So inferior vena cava will go up to the heart, taking blood basically back to the heart for circulation, and what's coming out of the liver is the hepatic vein. So hepatic vein is getting blood out of the liver and takes it to the inferior vena cava to go back to the heart. And of course, oxygenated blood will also come to the liver to feed the liver tissue from the hepatic artery. Now, what's important in the with the liver system is that there's also the portal vein. So portal vein is not connected to the heart. The portal vein will basically take blood out of the colon, the small intestine, pancreas, stomach, and the spleen, and take it back to the liver for filtration, and then it goes to the inferior vena cava to go back to the heart for circulation. So, for example, as you digest things and your body absorbs food or other substances, before they go into circulation, they go through the portal vein to go through the liver first, so that the liver can filter any toxins and do metabolism of amino acids, carbohydrates, other things, and then send the blood back to the heart for going back to circulation. So it is really important to know what the portal vein is connected to, because when there's problem in the liver and blood cannot go into the liver, you will have portal hypertension. So if there is increased resistance in the portal vein, that is referred to as portal hypertension, which is different than the hypertension that we normally say. So when you say somebody has hypertension, we're talking about the systemic hypertension in the systemic circulation. But portal hypertension is in particular in the portal vein, and that happens in patients with cirrhosis. And the reason for that is that if there is fibrosis in the liver, blood cannot get through the liver as easy as it used to be. So there's building of pressure inside the portal vein, and that is referred to as portal hypertension. And it is really important to know which organs it involves, because when it comes to complications, this portal hypertension will affect all these organs. So the spleen, the stomach, the pancreas, small intestine, and the colon. Now, liver fibrosis is progressive. So once you have liver injury, and we'll talk about some of the causes of injury to the liver tissue, fibrosis will cause injury to the hepatocytes or the liver cells, and as time goes on, this leads to portal hypertension. And because of those organs that are involved with the portal system, it can lead to decompensation. So when we say decompensation, we refer to a few complications of cirrhosis. In particular, ascites is one of the complications of cirrhosis. When someone develops ascites, 10-year probability of developing ascites is actually about 47%. So almost half of patients with cirrhosis are likely to have ascites within 10 years. And once they develop ascites, about 15% of them die within a year, and up to 44% die within 5 years. So this is not good. Once you have decompensated cirrhosis, there are really bad outcomes. One thing that's also related to ascites is something referred to as spontaneous bacterial peritonitis. So ascites is basically fluids in the peritoneal space, and these fluids can actually get infected by bacteria, which is also considered a complication of cirrhosis. Another thing that can happen is hepatic encephalopathy. About 28% of patients with cirrhosis are likely to have hepatic encephalopathy within 10 years. And also a quarter of patients are likely to have variceal hemorrhage. Now, variceal hemorrhage, it can be esophageal varices in more than 1/3 of patients within 3 years of diagnosis. Other complication that we will not talk about, which is beyond the scope of this course, is hepatorenal syndrome and also hepatocellular carcinoma, which is basically cancer of the liver. Now, when it comes to clinical presentation, it's a matter of whether cirrhosis is compensated or decompensated. Typically, patients who are compensated are asymptomatic. Now, as cirrhosis progresses into more advanced stages, that's where patients start to have symptoms. Beyond symptoms, also there are laboratory values that will also be abnormal. In particular, there will be hypoalbuminemia, and that is because albumin is is a protein which is synthesized in the liver. So if the liver is not working, proteins are not synthesized, so you will have low albumin. There will also be elevated prothrombin time. Prothrombin time is a measure of body's tendency to form clots, and this is something you will learn more about in patient care too. So because body's tendency to form clots depends on clotting factors, which are proteins, and if someone has cirrhosis and cannot make enough proteins, there are not enough clotting factors. So it takes the body longer to form clots. So that's why we have elevated prothrombin time. So prothrombin time is basically the time it takes to form clots. So it takes longer to form clots. There's also thrombocytopenia, which is basically thrombocytopenia means low platelets. In particular, when someone has cirrhosis, platelets will be less than 160,000. So you should expect, if someone has cirrhosis, platelets should already be less than 160,000. There will also be elevated alkaline phosphatase or ALK-Phos, and also elevated transaminases. So AST and ALT are the common transaminases. Now, here are some reliable resources. When it comes to liver diseases, we have AASLD is the organization in the US. So AASLD is the American Association for the Study of Liver Diseases. So most of the guidelines are made by this organization. Now, the European counterpart is the EASL, or the European Association for the Study of the Liver. The reason I have listed EASL is because one of these guidelines, they have actually joined forces to develop a guideline together. So AASLD and EASL together. And also we have the American College of Gastroenterology. When it comes to GI bleeding, they have guidelines. So for gastroesophageal varices and variceal hemorrhage, we have a AASLD guideline from 2007. For ascites, we have AASLD guidelines from 2012. For ulcer bleeding, we have American College of Gastroenterology guidelines from 2012. For hepatic encephalopathy, we have we have AASLD and EASL together making a guideline that was published in 2014. For portal hypertensive bleeding, there's a 2016 guideline by AASLD. And also ACG recently released a guideline for evaluation of abnormal liver chemistries. So the first learning objective is identify common causes of cirrhosis and its complications. Now, when it comes to cirrhosis, the first thing is things that will cause inflammation in the liver. So the most common one is hepatitis, NAFLD, and alcohol. So NAFLD is non-alcoholic fatty liver disease, and then of course you have your alcoholic liver disease. So whether it's alcohol or non-alcoholic, and as well as hepatitis, all of these will lead to inflammation. So when you have inflammation in the hepatocytes, over time it can cause damage. So this damage to the hepatocytes is referred to as fibrosis. So and of course fibrosis is a term that means damage to the cell. So it can be any tissue can have fibrosis. For example, you can have pulmonary fibrosis, you can have renal fibrosis. So that's why it's important to say liver fibrosis. So if you're talking about the fibrosis in the liver, you have to specify that you're talking about liver fibrosis. Now, over time, as liver fibrosis progresses and more damage is done to the hepatocytes, it will lead to cirrhosis. So cirrhosis is specific to the liver, so you do not have to say liver cirrhosis. When you say cirrhosis, people know that you are referring to the liver, because only the liver can have cirrhosis. Other organs will not have cirrhosis. Now, the major causes of cirrhosis are, of course, chronic hepatitis B, chronic hepatitis C, alcoholism, and non-alcoholic steatohepatitis. So NASH is a specific type of NAFLD. Now, there are some common triggers of cirrhosis decompensation. The number one trigger is alcohol. So patients who have cirrhosis should not be drinking alcohol. So some of the things that can happen is variceal hemorrhage, cardiomyopathy, and of course alcohol can accelerate progression to hepatocellular carcinoma. Another thing that patients with cirrhosis should not be on are NSAIDs. So this is obviously the structure for ibuprofen, the most common NSAID. And NSAIDs are available over the counter, so it is very important to educate the patients and let them know that they should not be taking NSAIDs. And the reason is NSAIDs, in particular in patients with cirrhosis, can lead to variceal hemorrhage. It can lead to ascites because it can cause fluid retention because of its action on the kidneys. And of course, since it does act on the kidneys, it can also lead to acute kidney injury. So if someone's liver is not working and also their kidney stops working, that's not good. And then the last thing is dietary sodium, because sodium will cause fluid retention, which lead to ascites. Just like NSAIDs, NSAIDs will cause fluid retention, causing ascites. The same is true with sodium. So it is recommended to limit sodium intake to less than 2 grams a day. The next learning objective is evaluate a patient's liver by assessing liver chemistries and using Child-Turcotte-Pugh classification. Now, here's you will probably hear the term LFTs, and LFT stands for liver function test. So when people in general say LFTs, they are referring to aminotransferases. They are referring to AST and ALT. Now, American College of Gastroenterology actually released guidelines on evaluating abnormal liver chemistries, and they said that basically aminotransferases and alkaline phosphatase and bilirubin are markers for liver injury, and they say nothing about liver function. So therefore they said you should not call them liver function tests. Instead, you should call them liver chemistries. So liver chemistries or even liver tests, because they tell you nothing about the liver function. So people will, you will probably hear doctors and other pharmacists say LFTs, and so just know that they're referring to AST and ALT, but it's not accurate to call these LFTs. We should call them liver chemistries. Now, the liver function tests, the actual liver function tests, are albumin and prothrombin time, because these two tell you specifically about the function of the liver. So if somebody's prothrombin time is elevated, you know that the liver function is affected. Whereas the rest of these, they're not very specific to liver function. They could be very, for example, if you have some acute injury to the liver, for example, drinking alcohol, and someone who does not have liver disease but they drink alcohol, AST and ALT will be elevated transiently, and then it goes back to normal. So it really just tells you about the injury to the liver, but nothing about its function on a chronically. Between AST and ALT, ALT is more specific to the liver. One thing to note is that bilirubin or T-bili. Oh, by the way, on the right side I have you will see the common fish bones for lab values. Don't be intimidated by saying fish bones. So the top one is the most common one, is the fish bone for metabolic panel. So you have sodium, potassium, chloride, bicarb, BUN, and serum creatinine and glucose, serum glucose. This is what you will see more commonly. There's also this fishbone for complete blood count, or CBC. So white blood cell, hemoglobin, hematocrit, platelet. Now when it comes to liver assessment, you need to know platelet, because patients with cirrhosis have platelets less than 160,000. So platelet is important when it comes to liver assessment. And then this one is less common. The vertical fishbone. A lot of people don't use it. I personally use it. So if people who do not use it, they just basically write out these numbers. But these are, the reason I like this is because you will, pretty much majority of these are related to the liver. So here on the right hand side you have AST, ALT, alk-phos, T-bili, then albumin, protein, and calcium. So one thing to note about bilirubin is that total bilirubin equals direct bilirubin plus indirect bilirubin. And direct, another way of saying it is conjugated bilirubin and unconjugated bilirubin. Basically, conjugate means if it's bound to protein, versus unconjugated is a free bilirubin. Usually when most labs, they measure T-bili. If T-bili is normal, there is no need to, it's normal. So if T-bili is normal, both direct and indirect will be normal. Now, if T-bili is not normal, if it's elevated, then they order more tests to get the direct bilirubin and also indirect bilirubin, because it will tell you more specifically what's causing T-bili to be elevated. If the elevated T-bili is mostly due to direct bilirubin, that indicates that there's hepatocellular dysfunction. When it comes to liver function tests, albumin, it will not always be low in patients with cirrhosis. As cirrhosis gets progress into more advanced stages, that's where albumin starts to go low. So normal albumin is between 3.5 to 5.5. So if it's less than 3.5, that's where you start to have problems. For example, if you have drugs that are protein bound, they are bound to albumin. So if you do not have enough albumin, that means that drug will not be around as much. So it can affect drug dosing. Another important thing about albumin is that the half-life for albumin is about 3 weeks. So there's no need to check albumin every day. So if you check somebody's albumin and it's normal, there's no need to check it every day, if they're in the hospital. Now, if it was low and you were giving them albumin to replace the albumin, sure, you can check it every day. But in general, if you check somebody's albumin and it's 3.5, there's no need to check a week later to see if it's still normal, because the half-life is 3 weeks. It doesn't fluctuate that quickly. And of course, prothrombin time, and so also you can use INR. INR is the International Normalization Ratio, which is the standardized version of PT, or prothrombin time. So if PT or INR are elevated, that also tells you that the liver function has worsened. Now, a couple of things about other lab values. So one thing is that with calcium, because calcium is protein bound, if your albumin is low, you need to adjust. You need to correct calcium. So calcium may artificially look low, and that's only because you have low albumin in patients with cirrhosis, so you need to correct for it, and there's an equation for it. Basically, the equation is corrected calcium equals whatever calcium you measured in the blood plus 0.8 times 4 minus serum albumin. Another thing that's important in patients with cirrhosis is sodium levels. So patients with cirrhosis can also have chronic hyponatremia. So in general, when somebody's sodium is less than 135, we say that they have hyponatremia, and we start to correct it, give them sodium replacement to make sure sodium is normal. and it becomes very dangerous if it becomes really low. However, in patients with cirrhosis, they can actually have chronically low sodium levels, and that's because of SIDs. Because they don't have enough albumin in circulation, the body cannot hold on to fluids because of osmotic pressure. So fluids escape vasculature and go into peritoneal space, and because fluids keep going out of vasculature, then sodium levels will be low. Lastly, about AST and ALT, so every lab will give you a normal reference range for it. American College of Gastroenterology actually could not give a reference range for AST because it's extremely variable, and between different labs you will get different reference ranges. They did say that for ALTs, typically the normal range is less than 33 for males and less than 25 for females. However, because there's so much, different, I couldn't ask you to memorize like a specific reference range. And the way people interpret it is that, we consider it abnormal typically when it's, more than 3 times the upper limit of normal for that specific lab. So typically, if AST and ALT are more than 3 times the upper limit of normal, we consider it abnormal. Now, when it comes to the actual measurement of liver fibrosis, measurement and assessment of liver fibrosis, historically, the liver biopsy was considered the gold standard for diagnosing cirrhosis. However, it is no longer routinely done. Now, back, when liver biopsy is actually done, the way that they actually assess, so they will actually take the tissue sample and they will do histology on it, and they will score it. So there's the Metavir fibrosis score from F0 to F4, and this is, of course, from this is a progressive scale, so it goes from mild to more severe, with F4 being the actual cirrhosis. So F0 is almost absence of fibrosis, and it progresses from F1, F2, F3, and then F4 is cirrhosis. And this is with Metavir fibrosis score, which is common in the US. There's also the Ishak fibrosis score that goes, it's the same concept, but it goes from 0 to 6, and 6 being cirrhosis. Now, this is an invasive procedure, so you will have to use a needle to go into the liver and take tissue out. So it's not very pleasant. Other things that we can do, especially for pharmacists, you can actually, there's an equation that you can use which will give you the probability or the likelihood of having advanced fibrosis or cirrhosis. So the fibrosis 4 or FIB4, here's the equation, and you do not have to memorize this equation, but basically you have age times AST divided by platelet times square root of ALT, and whatever number you get, if it's greater than 3.25, there's a 97% specificity for having cirrhosis. At the same time, if it's less than, so whatever you calculate, if it's less than 1.45, it's unlikely that the patient has cirrhosis. So there's a 81% sensitivity with that. So this is a simple equation that's routinely used in the clinic. There's a more complex equation called FibroSure. So it uses 6 serum biomarkers. It's more accurate than FIB4, but it's more difficult to use. So I see most people use FIB4. And then, of course, because equations just give you probability, so you don't really know for sure. In order to know for sure, you either need to do liver biopsy, or more recently we have elastography, transient elastography. So FibroScan is what we use. Basically, this is not something pharmacists can use, but hepatologists will use in the hepatology clinic. With fibroscan, basically they use ultrasound and it's elastography. So they basically use ultrasound to have the waves towards the liver, and then it will reflect back, and then based on the elasticity of the tissue, they can measure the pressure, and it's correlated to certain stages of fibrosis. So as fibrosis progresses, the tissue becomes more stiff. So these ultrasounds, when they reflect back to the detector, the pressure will be different. So based on that, they can tell you exactly what stage of fibrosis the patient is in. Now there are of course some limitations with it, but this is what's more routinely used because it is less invasive. Basically all you do is you use a ultrasound gun to shoot ultrasound waves at the patient, so they don't really feel anything, so it's convenient. And once someone has cirrhosis, everything I said so far is to measure fibrosis and then eventually identify cirrhosis. But once somebody has cirrhosis, we need to classify cirrhosis. So once somebody has cirrhosis, we use the Child-Pugh classification. So you do not have to calculate the score on a patient, but you need to understand the class A, B, and C and what they mean. So based on this scoring system, so 5 to 6 would be Child-Pugh class A, and then 7 to 9 is class B, and then 10 to 15 is class C. What's important to know is that class A is considered compensated cirrhosis, whereas class B and C are decompensated cirrhosis. And C is more severe than B. So it's, at class C cirrhosis, basically the patient needs to get liver transplant. The next learning objective is, given a patient with portal hypertension, recommend appropriate pharmacologic prophylaxis to prevent clinical decompensation. What exactly do we mean by portal hypertension? So there is the hepatic venous pressure gradient, which is the difference in pressure between the portal vein and the hepatic vein, and it's normally 3 to 5 millimeters of mercury. So anything above this range is considered portal hypertension, and then the severity of it depends on how high it is. So if it's more than 5 but less than 10 millimeter of mercury, it's referred to as mild portal hypertension, whereas if it's greater than or equal to 10 millimeters of mercury, it is referred to as clinically significant portal hypertension, or CSPH. So we do use these two cutoffs to classify the severity of portal hypertension. Now, if someone has decompensated cirrhosis, for the most part they happen to have an HVPG of greater than or equal to 12. So it's not to say that if anybody who has greater than or equal to 12 has decompensated, but in general, anybody who has decompensated cirrhosis, they will have a HVPG of at least 12 millimeter of mercury, and I will explain more about these. But first, let's see how we actually measure hepatic venous pressure gradient. So that's how HVPG is measured. Now, when we say compensated portal hypertension, note that there are no complications. So complications of portal hypertension is absent, whereas you will have complications when it's decompensated. So those complications include acute variceal hemorrhage or bleeding, and also if someone had previous variceal hemorrhage without other complication, or previous variceal hemorrhage with other complications. Now let's take a look at mild portal hypertension. So in mild portal hypertension, which is defined as HPPG of greater than 5 but less than 10 millimeters of mercury. No varices or other complications are present, so this is in general in compensated cirrhosis. There is very low risk of clinical decompensation in the following 5 years based on the studies that we have. So the goal of therapy for these patients is to prevent development of clinically significant portal hypertension. So that would be if you have a HPPG greater than or equal to 10 millimeter of mercury, and that is our goal, to prevent that. So how do we do that? So first and foremost is eliminating or suppressing the etiologic agent. So for example, if someone has Hep B or Hep C, if you treat that, then you can potentially prevent progression from mild portal hypertension to clinically significant portal hypertension. One thing that happens often is if patients have alcoholic cirrhosis, so the easiest thing for them is to stop drinking. And also if you have other causes, one example is if someone has iron overload, that can cause oxidative stress to the liver. So if we limit that iron overload and reduce the iron content, then we can potentially prevent progression from mild portal hypertension to clinically significant portal hypertension. Now, one thing that could potentially be beneficial is the use of statins in this patient. Statins decrease hepatic fibrogenesis. They improve intrahepatic endothelial dysfunction. They reduce portal pressure and also improve liver perfusion and liver function. Now, at this time, we do not have prospective randomized trials of statins in patients with compensated cirrhosis. So, this is not a strong recommendation, but, we could potentially put patients on Zocor 20 milligram for 1 month and then 40 milligram daily after that. This is one thing that's been shown with limited data to be beneficial. Now, other drugs that act on portal flow, for example, non-selective beta blockers, and I will talk about how non-selective beta blockers help in general. Those drugs will be mostly ineffective if patients have mild portal hypertension. And the reason for that is that these patients with mild portal hypertension, in these patients, hyperdynamic circulatory state is not fully developed, so using a beta blocker will not really help them. Next, we have patients who progress into clinically significant portal hypertension. So this is defined as HPPG of greater than or equal to 10 millimeters of mercury. So there should be an equal sign here. So for these patients, the goal of therapy is prevention of clinical decompensation. For management of this patient, there is no evidence at present to recommend the use of non-selective beta blocking agents for prevention of varices. And that's because in 2005 there was a study that was published in New England Journal of Medicine that compared timolol to placebo, and there was no difference between timolol and placebo. So for that reason, beta blockers are not recommended. Non-selective beta blockers are not recommended in this patient at this time. You can still continue any management strategies that were applied to mild portal hypertension for these patients as well. And finally, patients progress into gastroesophageal varices. Now, for this patient, endoscopically proven GEV or gastroesophageal varices are proven through EGD. So EGD, I will talk about EGD in a little bit, but it stands esophageal-gastroduodenoscopy. So basically, you can just, for sure, you can call this endoscopy. And I'll show you how EGD is done in the next learning objective. Now, the lowest HPPG in this patient is typically 10 to 12 millimeters of mercury. The goal of therapy is primary prophylaxis of variceal hemorrhage. So at this point, patients do have varices. So what we want to do is prevent these varices from bleeding. Now, in studies, it's been shown that if we reduce the HVPG to less than or equal to 12 millimeter of mercury, or if you reduce the HVPG by at least 20% from baseline, it's been shown to be protective for development of variceal bleeding. So if we do, let's see how we can actually reduce that HVPG by medical therapy or pharmacologic therapy. First, let's look at different patient populations because GEV is very broad. So let's talk about prevention of first variceal hemorrhage in patients with medium or large gastroesophageal varices. So these are varices in the esophagus. So for these patients, it's recommended to use non-selective beta blockers. So propranolol and timolol are the two non-selective beta blockers that have been studied. In addition to non-selective beta blockers, carvedilol has also been shown to be effective, and also endoscopic variceal ligation or EVL is recommended. But combination therapy with any of these is not recommended. So just a single agent. So either a non-selective beta blocker, carvedilol, or EVL. For small esophageal varices, again, non-selective beta blockers are recommended if patients has high risk. Carvedilol has not been studied in this patient, so it's not recommended. So if you do use beta blockers, what constitutes optimal response is if HVPG is reduced to less than or equal to 12 millimeters of mercury, or if you decrease HVPG by at least 20% from baseline. Heart rate, although we do monitor heart rate, it does not correlate with changes in HVPG, but we do monitor it for safety. When it comes to gastric varices, it can get really complicated. In general, non-selective beta blockers are recommended, but the data is not as strong. The data are not as strong for gastric varices as it is for esophageal varices. So for the most part, just focus on esophageal varices. Now here are the recommended doses for the different beta blockers. So propranolol 20 to 40 milligram by mouth twice a day, and we do adjust the dose every 2 to 3 days to maximum dose. And we want to target a resting heart rate of 55 to 60 beats per minute, and we want to maintain systolic blood pressure at 90 millimeters of mercury or greater. So if the systolic blood pressure drops under 90, you need to discontinue the beta blocker. Or if the heart rate goes under 55, because at that point it's not safe to continue these agents. Now for nadolol, 20 to 40 milligram by mouth once a day is recommended, with the same therapy goals for heart rate and systolic blood pressure. For carvedilol, we start with 6.25 milligram once a day, or you can do 3.125 milligram twice a day, and we only monitor systolic blood pressure. So carvedilol doesn't affect heart rate as much as non-selective beta blockers, so there's no need to target a heart rate of 55 to 60. And of course for EVL, which is a procedure, it's done every 2 to 8 weeks until eradication of varices. The next learning objective is, given a patient with variceal hemorrhage, design appropriate pharmacologic management. For esophageal variceal bleeding, patients are generally considered decompensated. Acute hemorrhage is a medical emergency, so patients typically need to be admitted to the ICU. Goal of therapy is to control bleeding to prevent early recurrence within 5 days and prevent 6-week mortality. Now, of course, when patients have active bleeding, what you want to do is to assess them to see if they need blood transfusion or packed red blood cell transfusion. In general, we do use the restrictive strategy. So that means if hemoglobin is less than 7, then they need transfusion to maintain 7 to 9.
This is in general. So there are, if patients do have cardiovascular comorbidities, then we actually use a hemoglobin cutoff of 8. So if for those patients, if hemoglobin is less than 8, then they need to get transfusion. Now, once patients with variceal bleeding, once patients with varices they start having variceal hemorrhage, they do need to get antibiotics. So ceftriaxone 1 gram once a day for a maximum of 7 days should be started as soon as possible. And that's because patients with variceal hemorrhage are at high risk of getting systemic infection, which is associated with high mortality. So we do treat them with ceftriaxone. They should also be started on vasoactive agents as soon as possible, and I will talk about these agents in a little bit. And then once these strategies have been taken care of, then EGD should be performed within 12 hours of admission, once the patient is hemodynamically stable. So now let's talk about EGD, or esophageal-gastroduodenoscopy. So once EGD is performed and variceal source is confirmed or suspected, then EVL should be performed. For some patients, an early or preemptive TIPS within 72 hours from EGD or EVL may be beneficial, up to 7 days. Now, if patients do not get TIPS, then vasoactive agents that were started before EGD, they should be continued for 2 to 5 days. And also, at this point, patients should be started on non-selective beta blockers once vasoactive drugs are discontinued. So, which happens after 2 to 5 days. Now, transjugular intrahepatic portosystemic shunt or TIPS is a procedure that basically connects, because of the increased pressure in the portal vein, what they do is they basically place a stent in here to basically increase the blood flow to decrease the pressure that was building up in the portal vein. So that's something that you can do in order to decrease the portal vein pressure, which can potentially decrease the bleeding risk from or the bleeding rate from the varices. Here are the vasoactive agents for acute variceal hemorrhage. So for the most part, octreotide is what we use. The initial dose is 50 microgram IV bolus, which can be repeated in the first hour if ongoing bleeding is going on. And then we do continuous infusion of 50 microgram per hour. And this goes 2 to 5 days. So during those 5 days, then you'll have some sort of procedure to stop the bleeding. And then once you stop the octreotide, then you start your non-selective beta blockers. Other agents include vasopressin, somatostatin, and terlipressin. So that was for esophageal variceal bleeding. For gastric variceal hemorrhage, pretty much the initial management is similar. Endoscopic therapy is really important for these patients. So basically the scope goes into, now this picture is in the esophagus, but the same concept applies to the stomach. So the scope goes in and finds the site of bleeding. And then they can either have cyanoacrylate injection, or they can actually do ligation. So once they ligate the varices, it will stop the bleeding. So once acute variceal bleeding is taken care of, we want to prevent this from happening again. So we do have secondary prophylaxis of variceal hemorrhage. When it comes to esophageal variceal bleeding, patients who recover from the first episode have a high rebleeding risk, as high as 60% in the first year, and mortality can be as high as 33%. So goal of therapy for this patient is prevention of additional complications such as variceal rebleeding, and also to improve survival. So, because mortality rate is high, we want to decrease that mortality rate. So first line recommendation is to use a combination of non-selective beta blocker and EVL. So once patients get ligation, we do start the non-selective beta blockers on these patients. And the patients with TIPS placed do not need to, non-selective beta blockers or ligation. So TIPS is pretty effective. In fact, if patients who don't get TIPS and they are on non-selective beta blocker and ligation and that fails, so they get rebleeding, then TIPS is definitely recommended for these patients. For gastric variceal hemorrhage, again, non-selective beta blockers with endoscopic variceal therapy is recommended. Another thing that can actually happen for gastric hemorrhage is something that's called balloon occluded retrograde transvenous obliteration, or BRTO. So in this picture you can see what this means. So basically they deploy these balloons to basically occlude the source of the bleeding. That way you can stop the bleeding by just basically blocking the source of the blood.
The last learning objective is, given a patient with non-variceal upper gastrointestinal bleeding, recommend pharmacologic management.
So upper GI bleeding is defined as bleeding from the esophagus, stomach, or duodenum. In patients with cirrhosis specifically, upper GI bleeding could be from varices. So variceal bleeding account for 60 to 65% of upper GI bleeding in patients with cirrhosis. Now, erosions are breaks confined to the mucosa and should not cause severe bleeding because veins and arteries are not normally present in the mucosa. So while variceal bleeding can happen in cirrhotic patients, in upper GI bleeding can happen in anybody, whether they have cirrhosis or not. So in general population, upper GI bleeding can happen, typically due to peptic ulcers. So here are different causes of upper GI bleeding in anybody. So varices obviously happens in patients with cirrhosis, but for those patients who do not have cirrhosis, the most common is peptic ulcer, which can also happen in patients with cirrhosis. And you guys learned about peptic ulcers yesterday. It's typically due to H. pylori infection or NSAID induced. And there are less common causes of upper GI bleeding, but since we don't have time to cover every topic, we will in this topic I will focus on bleeding from peptic ulcers. Initial therapy before endoscopy. So obviously the main strategy for stopping the bleeding is endoscopy. So the question is, what should we do before the patient actually gets the endoscopy? Because the patient needs to be hemodynamically stable. So again, transfusion of packed red blood cells with the same cutoff. So hemoglobin less than 7 in general, or less than 8 if patient has pre-existing cardiovascular disease. There's the question of whether proton pump inhibitors are effective or should we start them before endoscopy. So in general, pre-endoscopic PPIs may be considered, typically 80 mg IV bolus followed by 8 mg per hour continuous infusion. However, PPIs do not improve clinical outcomes such as further bleeding, surgery, or death. If endoscopy will be delayed or cannot be performed, PPI is definitely recommended to reduce further bleeding. And then, of course, the endoscopy itself happens, which is the most effective way of controlling the bleeding. And then once the patient gets the endoscopy, after successful endoscopy, I should say, PPI therapy, again with 80 mg IV bolus followed by 8 mg per hour continuous infusion for 72 hours should be given to patients who have an ulcer with active bleeding, a non-bleeding visible vessel, or an adherent clot. So these are high-risk patients. Patients with ulcers that have flat pigmented spots or clean bases can receive standard PPI therapy, such as oral PPI once daily. Now, in this picture, you can see different recommendations for patients based on their risk. So the risk is determined through the endoscopy. So once the patient gets scoped, based on what they see through the, through the endoscopy, they can either have a clean base, they can either have flat pigmented spot, adherent clot, or active bleeding or visible vessel. So in general, adherent clot and active bleeding or visible vessel are considered very high risk, whereas clean base is considered the least risky for as far as rebleeding and mortality. So for those patients who are low risk, basically through endoscopy they find what's going on, but they don't necessarily do endoscopic therapy if they're low risk. And then what they can do is, since these patients are low risk, you can have once daily PPI therapy. And then patients typically, if there's a clean base, they get discharged and go home. If they have a flat pigmented spot, they may be observed for 1 or 2 days and then get discharged, assuming there are no other problems to keep them in the hospital. Now, for high-risk patients, basically, obviously, if you have active bleeding, you do need that endoscopic therapy to stop the bleeding. If they have adherent clot, it may be, endoscopic therapy may be considered. And then for medical therapy, after endoscopy, you do need intensive proton pump inhibitor therapy. And these patients are typically held in the hospital for 3 days, just to observe them to make sure they don't have rebleeding. And then after 3 days, unless they have other reasons to stay in the hospital, they can be basically discharged if the bleeding has been managed beyond 3 days. Now, what exactly does intensive PPI mean? So, based on the latest guideline that we have in North America from 2012, the recommendations were 80 milligram IV bolus followed by 8 milligram per hour continuous infusion for 72 hours. More recent data suggests that you can also use PO or IV bolus, such as 80 milligram, followed by intermittent high-dose PPI therapy, such as 40 to 80 milligram twice daily for 3 days. Now, this is at the moment, some institutions are basically implementing this. The European guidelines have updated in 2015, and they have used that study, which you were required to read, to make this recommendation. Our guidelines haven't updated yet, so they still recommend 80 milligram followed by 8 milligram per hour continuous infusion. But some hospitals are starting to implement the intermittent dosing. Now, if patients have high risk, they will require 2 weeks of twice daily dosing of PPI, and then they can go to once daily dosing. And what high risk means is patients with findings, with endoscopic findings and clinical factors that are of high risk, such as hemodynamic instability, older age, major coexisting conditions. Those patients need to be on twice daily PPI for at least 2 weeks before going to daily. Otherwise, they can just continue once a day PPI. So once we manage that episode of bleeding, we want to prevent this from happening again. So we do have secondary prevention of ulcer bleeding. Patients with H. pylori, basically you need to treat H. pylori. So eradication of H. pylori is recommended for these patients to prevent this ulcer from happening again. Patients who are on NSAIDs, that excludes low-dose aspirin. I'll talk about low-dose aspirin in a little bit. But if patients are on NSAIDs and they had NSAID-induced ulcer bleeding, they should discontinue NSAIDs. and if they really need that NSAID, they should be on a COX-2 selective NSAID, and they should get the PPI as long as they are on a COX-2 selective NSAIDs to prevent bleeding. Now, for low-dose aspirin, it's a question of why they are getting that low-dose aspirin. If it's for primary prevention of cardiovascular disease, it's recommended to discontinue aspirin permanently because the risk outweighs the benefit. Now, if that low-dose aspirin is for secondary prevention of cardiovascular disease, now the benefit actually outweighs the risk, so it is recommended to resume aspirin 1 to 7 days after bleeding stops in most patients. And once you do, the patient should continue PPI therapy in the long term. So as long as they are getting aspirin, they should also be on a proton pump inhibitor. Now, that was for management of the ulcer bleeding. Now, in general, patients who have GI bleeding, the question is, do they need antibiotics for prophylactic antibiotics to prevent infection? So the question is, well, what patient population are we talking about when it comes to upper GI bleeding? So in patients with cirrhosis, if they have variceal bleeding, definitely they need short-term prophylactic antibiotics, as I mentioned earlier. It's shown to decrease rate of bacterial infection as far as increase survival. So we can decrease mortality by giving antibiotics to patients with variceal bleeding. Now, if you have non-variceal bleeding, such as ulcer bleeding, it's a matter of whether this is happening in patients with cirrhosis or no cirrhosis. So if you have ulcer bleeding in patients with cirrhosis, again, you need to use prophylactic antibiotics. There's data to show that patients who have cirrhosis and they have ulcer bleeding, or any other kind of upper GI bleeding, use of antibiotics significantly reduces bacterial infections, and it also seems to have reduced all-cause mortality, bacterial infection mortality, rebleeding events, and hospitalization links. So if someone has non-variceal bleeding and has cirrhosis, definitely use the same prophylactic antibiotics. Now, if someone has ulcer bleeding and they do not have cirrhosis, there is absolutely no data to support prophylactic antibiotic use. So if someone comes in with ulcer bleeding but they do not have cirrhosis, there's no need for antibiotics at this point. That concludes this presentation.